Good morning and welcome to the webinar, Creating a Trauma-Informed Hospital, Lessons from the Children's Hospital of Wisconsin. The Illinois ACEs Response Collaborative is really excited to bring you this webinar. The collaborative illustrates the power of systems-level cooperation to intervene in the transmission of adverse childhood experiences from one generation to the next. Our many successes have been grounded in a commitment to a collective impact framework, recognizing that no single organization or sector can build community resilience alone. The collaborative fills a critical role by drawing together leaders from different groups to think more broadly about ACEs and by coordinating our varied efforts to effectively move the dial. By expanding ACEs research in Illinois, learning from effective interventions in other states like Wisconsin, and strengthening the relationships among the groups in our state working to address ACEs, we can develop the policies and interventions we need to reduce ACEs and combat their harmful impact on our health. You can visit Health and Medicine Policy Research Group's website for more information, including policy briefs, including a health policy brief, and an environmental scan of trauma-informed programs. The collaborative would like to thank United Way of Metropolitan Chicago for its partnership in this collaborative and the following funders who support our critical work: the Health Federation of Philadelphia, Illinois Children's Healthcare Foundation, Crown Family Philanthropies, Polk Brothers Foundation, and the Otho S. A. Sprague Memorial Institute. The Children's Hospital of Wisconsin has been at the forefront of the movement as we lead the Healthy Chicago 2.0 Trauma-Informed Hospital Collaborative, a group of 16 hospitals in the Chicago area who have been working together to become trauma-informed healthcare systems. Please note that all participants are muted during the presentation, but please feel free to type any questions or comment in the chat box as the webinar is going on. We'll be collecting questions throughout the presentation and will facilitate a moderated Q&A after the 45-minute session. Afterwards, after the webinar, you will receive an email with the following: a survey, ways to participate in the collaborative, links to our website and materials, and a recording of this webinar. On to our distinguished presenters. We're extremely grateful to have Jennifer Hamill with us. She is the Early Childhood Development and Trauma-Informed Care Director at Children's Hospital of Wisconsin Community Services. She has been with the hospital for 22 years, leading its Child Abuse Prevention Fund for most of that tenure. She has a rich history in partnering with many of Wisconsin's not-for-profit agencies and Wisconsin Departments of Health, Children also know that home visiting is very, very critical. Of using the sanctuary model for youth serving professionals in the field of child maltreatment prevention, intervention, and treatment services. Dr. Parody has served as is a Master's of Public Health degree at the University of Rochester in Rochester, New York. Her areas of interest include the intersection of primary care and community-based organizations, as well as improving health equity for vulnerable populations. Without further ado, we will let our presenters take over.
Good morning, this is Heather Parody, and it's a pleasure to be with you today. What Jennifer and I hope to accomplish during today's talk is to describe the current state of Children's Hospital's Trauma-Informed Culture Shaping Initiative, to illustrate how the sanctuary model is working within our organization and plans for the future, to give you a brief overview of the evaluation that we have planned and are beginning to implement, and to share some information and have time for question and answers about ways to work and lessons learned. So our vision at Children's Hospital of Wisconsin is children's healthiest in the nation. That were developed as part of culture shaping work that help us to achieve that vision as an organization. Each principles that we treat, we are unique. As an independent children's hospital, our services at a glance include the following. We have traditional hospital-based care, both here in Milwaukee and also in the Fox Valley in Neenah, Wisconsin. We have a robust subspecialty care, and we have a primary care network that includes over 20 locations and 4 urgent care locations and continues to grow here in Southeast Wisconsin. And finally, we have a robust community services division where both Jennifer and I are housed. This includes school nurses within Milwaukee Public Schools, community navigators, and a violence intervention program. It includes child advocacy and welfare services here in Milwaukee and also statewide. And it includes the health plan. Our health plan cares for over 135,000 children and adults who are on Medicaid here in Southeast Wisconsin. In addition, we have statewide prevention, parenting, foster care, and adoption services that act under many grants and contracts. In all, our health system has over 5,000 employees and more than 40 locations. So why trauma-informed care? There's a variety of reasons why this work is important. First of all, it's the right thing to do. As you all know, adverse experiences during childhood or trauma has a high correlation with health problems later in life. Given this connection and our vision to have Wisconsin's children be the healthiest in the nation, being a trauma-informed health organization is essential. And we also know that the people who work within these service-providing systems can often be traumatized through the work that they do and the experiences they have with children. And finally, as part of our own culture shaping work, at our best, we know that we as a health organization will be at our best when we are trauma informed.
Oh, no, let me, sorry, we're having a little difficulty on this end with the slide advancing.
Apologies, our slides are a little bit frozen.
Yes. Let me just see now if I got out of there. No.
There we go. So our trauma-informed care and culture work falls primarily under the value of health. We use the following behavior statements to define our trauma-informed culture work. I foster resilience and growth in myself, my coworkers, and the children and families I serve. I use a trauma-informed lens and ask what has happened to you rather than what is wrong with you. I am committed to nonviolence and promote physical, psychological, social, and moral safety in my work environment. I understand how trauma and adverse childhood experiences impact health outcomes, and I recognize the impact that trauma and adversity have on children and families, my coworkers, and myself, and respond with trauma-informed practices. In this diagram, which we developed here, it shows the intersection of our current trauma-informed initiative with many of the other culture-shaping work that is currently going on within our health system. So the blue items indicate those programs that are available to all employees system-wide. And the green intersection shows those initiatives that are currently trauma-informed. So you can see that there's quite a lot of overlap of our trauma-informed work with our other culture-shaping initiatives that are already happening within the organization, even before we brought sanctuary model and language to this. And it will intentionally be interwoven with any new sort of culture-shaping initiatives that are coming along, such as our child and family experience work and our safety work. We are also working to intentionally crosswalk this within our existing culture work. You can see here one sample that we have of how the trauma-informed practice of emotional intelligence intersects with our values of health, integrity, and collaboration. Some of the guiding behavior statements that align with emotional intelligence and with those values. And also the At Our Best, which is our existing culture shaping work, as well as some of the sanctuary specific tools. And this crosswalk is meant to be intentional about the way that we interweave the culture shaping work so that it's not just seen as just another initiative, but really highlights the way that it exists within the framework that's already here and within our language. So why this model? Why sanctuary? Sanctuary is a fairly prescriptive model, but one of its benefits is that it also brings with it common language and tools, some of which can be implemented right away. The other benefit to Sanctuary that we see as an organization is that it actually roots itself in the parallel process. So it really understands that organizations behave in a way that is similarly reflected in the customers, clients, patients, families that it serves. And so it really recognizes that any sort of trauma-informed work needs to start internally with the employees of the organization itself before it can be reflected outward. So our work with the sanctuary model in the fall of 2015 began with an on-site needs assessment. And some of the things that our initial needs assessment found were the following: that leadership really needs to support this vision for change, and it needs to be a top-down approach if we really hope for the adoption of these principles. That we as an organization, speaking again to the parallel process, need to create an organizational trauma history to help understand how we as an organization have changed and how people have experienced that change as loss. And we need to recognize that our staff who deal directly with families who are oftentimes in crisis, how they can recognize and address the vicarious trauma that they experience. And finally, to create a trauma-sensitive culture to support these discussions for loss for both staff, clients, families, patients, and to develop shared language among staff and clients. And now Jennifer will take you through some of the specifics of the sanctuary model.
Okay. So the sanctuary model is a blueprint for organizational change around trauma-informed principles, practices, and culture. And it's comprised of 4 pillars, and all 4 pillars need to be operating simultaneously in order for the practice of sanctuary to be effective, because each one supports the other and complements each other in order to influence culture and climate. So the first one is trauma theory, and it's around understanding what happens to individuals when they are hurt, recognizing that behaviors are survival skills in many occasions, and it helps us to make sense of how those behaviors translate in an organizational setting and translate in a parallel process to how organizations may behave when staff are stressed and experiencing vicarious trauma. The commitments are values that we aspire to, the way in which we agree to be in relationships with each other and treat each other in order to mitigate the effects of trauma. The commitments listed or supported by Sanctuary align very nicely with our Children's Hospital of Wisconsin values and guiding behavior structure. SELF, which stands for Safety, Emotion, Loss, and Future, is a common language that we use to understand problems and solve them without blaming ourselves or others. And it's the way that we can define the most significant impairments that people face when they're exposed to trauma, and then it helps them move forward in terms of healing. And then finally, the Sanctuary Model Toolkit, which are the daily practices that reinforce our theory, the values, and the language, and helps us to build community. Okay. So why the commitments listed above? Well, because this is a blueprint for clinical and organizational change that promotes safety and recovery from adversity, it's important to have these commitments be very forward visible and defined clearly. So nonviolence attempts to give the opposite experience within the community that traumatized people may have experienced in their life. And it allows the organization to embrace and be intentional about policies, procedures, philosophies, and ways of interacting with each other that are nonviolent. Emotional intelligence creates an environment in which community members understand the relationship between their past experiences, their emotions and behaviors, and then responding and reacting in ways in which we are utilizing that tool in an emotionally respectful way. We can use and should be using emotional intelligence with each other in our workplace, as well as with the patients, families, clients that we are providing services to. Social learning is a way to promote collaborative thinking and problem solving to break dysfunctional and repetitive patterns through the exposure to others' perspectives and ideas. This also helps us to mitigate any isolating effects of shame by viewing mistakes as positive opportunities for learning as opposed to being opportunities to blame. Democracy requires active participation and empowerment in the service of replacing helplessness. And it really is giving a voice to those individuals who may not necessarily be decision makers in an organization, but promotes an opportunity for collaboration and support. Open communication creates a community that tolerates personal use. And we know that many times individuals who've experienced trauma may be operating from a place of shame, and that when there's not open communication, sometimes it feels like secrets are being kept in an organization. Social responsibility focuses on building a community in which people feel a sense of responsibility and care for each other, and the group as a whole in which people are held accountable for their actions. One of the primary guiding behaviors for children is accountability, and this falls very nicely within that current culture structure. And then growth and change presents a framework to evaluate current behaviors and focus on the future with goals and planning to break dysfunctional patterns. And as we in the healthcare field know, Our environment has been changing sometimes at a rapid pace in which we can't always keep up, and so acknowledging that growth and change is an important structure for us is a tenet that we really support. So I'm not going to list I'm not going to go through each of the items in the toolkit, but suffice it to say that these are the tools that are available through the sanctuary model, and all of the areas that I'll talk about in a little bit have been trained on each of these tools, and they're all implementing them in either in a similar or maybe even a very different way depending on how their department operates. These tools are meant to be daily practices, and they can act as an immunization to mitigate continued traumatization. So this is Anders' version of how Sanctuary can be implemented. And because we are such a large organization, we have taken the liberty to modify this for our own purposes and add some layers to this. And so we term it Sanctuary 2.0, the Children's Hospital of Wisconsin version. And you'll note that there is a steering committee that guides this work. But what's not noted on here is we have actually executive sponsors who are championing this work at the executive level to help remove barriers that we encounter as we do implementation throughout the organization. Our steering committee really handles implementation conversations about the who, the where, the what are the next steps we need to be taking. And then the core team, which is a group of folks who represent different levels of our organization, and they are diversified in terms of program type and have access to organizational resources that help to open doors for us in places, for example, educational services, where when we start doing enterprise-wide rollout, there will be some needs for us to interplay with ed services so that we can ensure that training is not only not duplicative, but is provided in a way that's utilitarian for each of the departments and units in our broad system. We have champion teams that work in each individual area that is phased in, and I'll spend a little more time talking about that when we talk about rollout. And really their charge is to live and breathe sanctuary model in their units and to really champion how that rollout looks in their own areas. This trickles down to the staff who are expected to participate in the daily practices, which in turn will impact patients and clients. And part of the sanctuary model requires some of the tools to be used with patients and clients. And for the most part, we are not embarking on that phase of sanctuary at the get-go. We're really focused internal to ensure that we can do spread internally first. And then, of course, the premise is that as we're impacting patients and clients because of the breadth and depth of services that we have here at Children's and the sheer numbers of individuals that we are reaching, that we will be impacting the Milwaukee community. So this is a sample of what the implementation is proposed to look like through 2020. And I'm sorry the screen is so small, it's hard to see, but our first rollout areas are noted on the first two lines of the time frame. We have, I'll talk a little bit about the executive sponsorship and our new core team. That was a change that we made from our initial rollout. And then moving into some clinical areas, looking at Q1 of 2018 to start some of that work. And identification of those clinical areas will be contingent on the how many initiatives the clinical areas are already undergoing. And we'll talk a little bit more about what those readiness conversations look like. The focus areas that we started with, we really started on very small because we were interested in doing some open case testing with some of our areas and really being, we were pretty unstructured in the first implementation areas. And so after we had the needs assessment completed, the executive team came together and had a conversation about which areas should we be looking at to start. And those areas included the community health plan, our insurance agency's Care for Kids program, which really focuses on managing the population of foster care kids through that insurance Medicaid structure. Our local Milwaukee Child Advocacy Center that does screenings, assessments, and forensic and medical screenings for kids where there's been an allegation of child abuse. And Project UGIMA, which is a violence intervention program that primarily works with victims of community violence and intersects with our emergency department, where the vast majority of the referrals come from for kids who have landed with community violence injuries, and our staff there are working with staff in the ER to receive those referrals. And then phase 2, we took a very different approach, and I'll talk more about that, using change management model, and we focused on our family case management area, which has a employee base of about 250 employees, primarily based in Milwaukee. And then 3 other areas, including my area, the early childhood development and trauma-informed care area, our community health navigators teams, and our school nursing units. So we have overlaid 2 different change management models in this project. The first is the Institute for Healthcare Improvements model for spread, and really paying attention to how intentional we are with engaging different parts of our organization in both understanding the model and then what is required to spread across the enterprise. And then we're using ProSci as well, because this is a change management model that our leadership team has embraced, and we use their ADCAR framework, which is looking at generating awareness so that we can generate desire for change, and then building on their knowledge and skills in terms of the ability to implement change in this particular circumstance, sanctuary, and then really providing the opportunities for reinforcement of that change across time. And these 2 change management philosophies really have core things in common, that leadership matters, and in fact, in the ProSci structure, we use the executive sponsor framework to forward and keep on the radar these large-scale change initiatives. And that leadership, executive sponsor leadership, really helps to pave the way at an executive level to help us open doors and remove barriers for the change that's going to happen. That decision-making matters at all levels, and that can't just occur from the top down. That in fact, as one of the values or commitments in Sanctuary in terms of democracy, that it is important to have recommendations that come up from our champion teams up through our executive sponsorship, so that when recommendations are being made around decisions, that feedback is considered in the decisions that get made at our core team, steering committee level, and executive team level. Communication and timing is critical. We spent quite a bit of time on the front end of implementation with our pilot areas being very sort of open in terms of the learning of what Sanctuary brings to our organization and how it interplays with our current culture shifting programs, the At Our Best program, as well as Best and Safest Care and other initiatives that we have in the system. Because we couldn't roll this out from a large-scale communication standpoint without really clearly understanding where the intersects are and how that's going to occur. Timing is also important, because we have to be thinking about how are we going to be onboarding new staff when training gets rolled out to different areas, and how does that maybe look different than how we're doing training today. And then training is from a change management perspective, is one of those very key elements. When you're starting with a new training opportunity in an organization that is already oversaturated with training requirements, we need to be very thoughtful about what that looks like, and how do we do training that is incorporated into current training opportunities. So for example, all staff are required to go through a day-and-a-half training of our At Our Best culture. And so we are charged with ensuring that we can embed some of the sanctuary and trauma-informed care concepts into that training opportunity so that we can minimize the other training opportunities that they may be required, that staff may be required to attend. And then we know that each department has its own training requirements. So our nursing staff have things that they need to be doing in order to maintain licensure and our ability to have an organization that is able to be certified by all of the certifying bodies. So that's just one example of some of those training considerations that we need to be keeping our eye on in terms of change management. And then sustainability, and I talked a little bit about this in terms of the training, but how do we embed this as not just from a training perspective, but as practices in the way that we provide business in our organization. Okay. Now, this is a sample of our sanctuary model implementation for phase 2, which was family case management. And again, I apologize for how small this slide is. But we started with our readiness conversations back in the fall with this department and really explored with family case management what initiatives they had on the table, how many staff are already being pulled into those initiatives, what is the timing for those initiatives to sunset, and where and when would there be bandwidth to be able to commit staff to be not only being trained, but to be seen as leaders through their champion team to roll out sanctuary in their area. We spent quite a bit of time in communication and training planning with the directors of family case management and planning for that data collection and what that would look like and how that might impact the way that they do their jobs. And then we spent 2 days training the directors and managers so that they would have a good sense of what the sanctuary model is and the tools that are a part of that. And then training supervisors, 30 of them, so that they could not only have buy-in, and we really sort of skewed our training to the ADCAR model in terms of creating awareness and desire for change, with anticipation that there may be some pushback. And frankly, there was not any pushback from the supervisors. They really embraced the concepts of sanctuary and wanting to move forward pretty quickly. The initial training of direct services staff, while it was slated to occur in early July, is being pushed into later August because of some other programmatic changes that are happening. And that there is a part of sanctuary that is really around ongoing concept review. And this is about the sustainability embedding of practices in that department. They've selected their champions and are beginning to pull together team meetings that will occur at a minimum monthly, but more likely more frequently than that. And then practicing tool adaptation and then figuring out what their ongoing training plan is going to look like. We will be learning more in terms of the evaluation process and feedback from them in terms of how their process implementation is working, and then we expect to have some opportunities for learning impact a little bit later in 2018 as we kind of roll out our phased-in evaluation structure. And then my team, which is composed of one staff person, is continuing to provide coaching and support to that department. But really, once we have the teams set up and ready to roll and trained, they can tend to be pretty self-sufficient, and we just need to go in and provide that support as is requested. So what do we think success is going to look like? Well, sort of high level, that we believe that trauma-informed care principles and guiding behaviors will be articulated as part of our children's values and guiding behavior structure and embedded into our At Our Best culture. That is ongoing conversations and work. That trauma-informed care is going to be integrated across all of our platforms. And so what does that mean by platform? Training systems is one, but the other is our look and feel of our internal intranet and how we connect folks to resources that we have available through our employee health and wellness benefits, through our family services area for critical incident management support, and then how we do best practices and evidence-based programming across all of our programs, and that other parts of our organization know what another part is doing with regard to trauma-informed care. I think the slide where you saw the Venn diagram, and we're just beginning to learn all of the parts of us that are doing things that are trauma-informed, and beginning to document that. And that is something that internally our staff don't know what each other is doing. Evaluating performance of our employees based on modeling of trauma-informed care practices. So what that means is in impacting our performance management systems. And that's more of a long-term goal. But if we are able to impact our systems and really evaluate employees based on some certain practices, we feel like we will be able to be further ahead. And then when our patients and clients and families are feeling valued, we know that we are providing trauma-informed services and support. And finally, success looks like success when we stop calling it trauma-informed care and it's just the way that we do business every day and the way that we think. So I'm going to toss this over to Dr. Parody, who's going to share with you some information about our evaluation.
So briefly, the evaluation that we have designed and are beginning to implement is a non-experimental, mixed methods, quality improvement approach to participants in the full implementation areas. So right now, within our own community services division. And we want to answer the following 2 questions about the extent and impact of implementation. The pilot programs that have already been trained will be administered post-retro pre-design, while the programs that have not yet started their training will be administered a standard pre-post design. So the measures that we have, as you can see, I did say it was a mixed method, so we have both quantitative and qualitative methods planned. Our quantitative include an online survey that we have developed here that does include the ProQual, the Professional Quality of Life, and Brief Resilience Scale, which are 2 published scales, as well as some of our own designed questions. We are also using found data to contribute to our analysis, so data sets that already currently exist here within children. So some of our employee commitment survey data, some of our safety survey data that is conducted annually, satisfaction surveys from patients and clients, and some of our retention and turnover records from human resources. The qualitative methods that are planned include some document analysis, the gap analysis that each implementation area performs, and then some focus groups.
So lessons learned. What have we learned and what are we still learning? Well, our phase 1 sites experienced some successes and setbacks. As I had mentioned earlier, the 3 pilot areas that we went into that was very unstructured. We had the way that we recruited individuals to participate on a champion team was very open, and essentially anyone that was interested in participating, we signed up to be on the champion team. I think one of the lessons that we learned from that experience is that while we had a very large number of people that were interested, we had many that sort of self-selected out, and we had others that really didn't have a full understanding of what it was going to take to participate on the champion team. And so we had folks that kind of middle of the game needed to remove themselves from the process. And so what that meant was we needed to go back and retrain, because we ended up adding new folks to the champion team, and then really sort of reset, if you will, the start clock for implementation in those areas, which began at the beginning of this year. We had our phase 2 sites that we decided to use a more structured change management approach, which is the approach that we will be using going forward. And I think that that's going to really sort of set a nice stage for acceptance and opportunity to for the toolkit to be used in a very intentional way. And it is the model that most of our system is used to using when change occurs in their departments. The evaluation is going to inform some tweaks that we will need to make going forward, and that evaluation will be rolling out soon. Actually, I think this coming week is when the first set of surveys will be going out. And then it's easy to do awareness raising. We have already on our e-learning site internally a Trauma-Informed Care 101 and an ACEs training. And staff are already required to take those as a baseline information. But it's always the next steps that tend to be more difficult. As to how do you change your practice when you know what you know about adverse childhood experiences, and what does that really look like in your department or in your clinic. We have I'm going to share some examples of things that we've learned. Early on in implementation, we had a very significant community violence event that occurred in Milwaukee during the day when many of our community services staff were in the field doing home visits or canvassing homes. And it was an event that really sort of forced or identified for us that we needed to be doing things a little bit differently from a safety perspective with our staff. None of our staff were physically impacted by what happened, but many of them were emotionally impacted. Many of our staff live in the neighborhood where this occurred, and we employed the tool of SELF to identify the losses, the safety concerns, the emotions around the event, the losses that the staff experienced, and then really sort of looked at what do we need to be doing differently, the future moving forward. And that event has led us to develop or not just the event, but the SELF tool has led us to develop a work group on specific event escalation and rapid communication protocols for our teams that work in the neighborhoods and for our teams of offices that are off-site from our main campus. And that work is undergoing right now. I don't know that we would have gotten to that level of intensity and intervention if we hadn't utilized the SELF model and allowed the staff that were impacted to share their feedback with us. Our Project Ujima team, from the get-go, because of the nature of their work, began using the tool of red flag reviews, and they were using them frequently so that they would, when an event occurred, when some sort of an event, whether it was external to their team or something that was occurring within the team, they would employ the red flag review almost immediately, and they would then do some problem solving. That has led this team to really become very gelled together. They had previously experienced quite a bit of turnover, and since they've been doing sanctuary tools, and in particular the red flag reviews, turnover has been at a minimum. And then finally, I just want to identify that when we have used this common language, it really gives us an approach to identify difficult situations, that people can at least utilize the language and calling in resources to support them. We have teams of staff who have been moved from a clinic site in our downtown area to a newer clinic site, but in a more needy area of Milwaukee. And it would have been, I think, for us an appropriate approach to use some of the sanctuary model tools to help the staff in that clinic adjust. And we did not do that, but it certainly gives us opportunity to think about how do we employ the tools in areas even when they haven't not yet been trained, but perhaps there's an event that's really demanding the attention that the tools and the common language can help to facilitate. And so this is what we strive for, not just happy, healthy kids, but a happy, healthy staff who are able to be resilient and are able to manage both their emotions, but also their interactions with their team members and others, so that we can move towards our vision of the healthiest kids in living in Wisconsin. So at this point, I think we're going to pause and take questions.
Great, thank you so much. And please do type your questions as they come in or as you have them. I will start with one. You had mentioned that you have a toolkit and that's used differently depending on what department you're in. Can you give some examples of how that would look different in different departments, like something very specific?
Sure. So one of the tools is community meeting. And essentially it's a way to gauge three things, sort of where individuals are on the term that we use here in children's is the mood elevator. So where are you today in the mood elevator? What is your goal? And who on your team can help you achieve that goal? And it's really to gauge, it's really to promote that collaboration and that teamwork. And it can be a very structured way to ascertain those goals, ascertain that information. We have some teams that have done implementation of community meetings, done it a little bit differently because their teams are not quite ready to identify what their emotions are. They're not comfortable in that space. And so it allows us to, it allowed that team to get in a place comfortable with community meeting before adding the level of emotions. And so, so the one team first started off by utilizing that identify your emotion, and then when it got a lot of pushback, they backed off and really just started focusing on, okay, what is your goal for today, and who on the team can help you. That's not how it's rolled out in other areas, and that's okay. Now that the team that I'm referring to, because I don't want to call out specific teams, but the team that I'm referring to that modified community meeting, now they are at a place where they're implementing it, identifying and putting a name to emotions. There is no, and let me just say this, there is no requirement to be completely transparent about why you're feeling the way you're feeling in that moment. It's just to acknowledge that you have a feeling and that if you need support, there are others on their team who are willing to reach out and support you.
Great, thank you so much. Okay, another question. So it sounds like you're using not only the sanctuary model, but you've been very intentional about having change management models as well. Can you talk about that a little bit more?
Sure. So, so there's some really great tools available through the Institute for Healthcare Improvement. And anyone, I would assume that many folks on this call probably already belong to them. But if you don't, it's a free, they just ask you to register, it's free, and you can get access to their materials. And one of the pieces of material, one of the materials that they provide is this planner for spread, or a spread planner. And it really asks very intentional questions about leadership and organizational support, and how it's aligned, because it's important that your work is aligned internally with your system goals, and that is happening at an executive leader level, since they are driving the direction of the organization. There are specific questions around how do you set up your project for spread, and really asking things around target population and what might a pilot look like, and who are the folks who do make decisions around that work, etc. And then really sort of being intentional about what does your communication strategy need to look like, and how are you going to be keeping tabs on both successes and lessons learned. And then the other model that we use, the ProSci model, is one that we actually have staff here at Children's who are trained as trainers, and it's a pretty intense 3-day training that leaders can go through to learn more about what the change management process looks like from the pro-sci lens, and very concrete tools that can be used to identify potential barriers to implementation and who are the key stakeholders that you need to include from the beginning. There's a whole tool around identifying how you're going to put together your awareness and desire plans, if you will, whether they're training plans or communication plans, and then what you do when you encounter pushback and resistance, because there's going to be resistance. That's going to happen, and that's a normal part of change. Not everybody accepts change on the same time frame, and so understanding sort of what tools you can employ to help bring people around is really helpful. So the pro-sci model is one that that we use pretty consistently in the organization.
That's really helpful to know how much structure you need for this. I'm curious, and we have a question about this. Did you consider any other models besides Sanctuary?
That's a great question.
Yeah, so when this work was being discussed probably 4 years ago, 5 years ago, at that time there was not an organizational change, trauma-informed care organizational change program that takes into consideration organizational trauma. And so the Sanctuary was selected, I think, after having done a search. I don't know, Heather, if you've got more that you'd like to add there.
So it's interesting watching this from a couple of different lenses. When I came to Children's, the Sanctuary model had already been selected and was just starting to be implemented, and we were getting trained. So I was able to jump right into that and immediately saw the benefits of it for our organization, as well as my experience at another healthcare organization that underwent some change. And as I say, the immediacy of some of the tools, as well as its focus on organizational change and the parallel process, made it very desirable. Where I have seen a little bit of struggle maybe in that it is a very prescriptive model. And when we are thinking about trying to implement with fidelity, that is maybe where we are at times feeling a little bit constrained. On the flip side, I have had the pleasure to work statewide with Fostering Futures Initiative, which is First Lady Tanette Walker's initiative around trauma-informed culture and care, and creating trauma-informed organizations at the county and state level. And they have utilized a little bit of a different model to bring about that culture change, and a model that has a little bit more flexibility to it. But where I have also seen some of those teams struggle a little bit is that because it is so flexible and so open, that I think sometimes taking that next step between trauma-informed awareness generating and education to what do we actually do has been a little bit trickier maybe for some of those teams. So there's pros and cons to any sort of trauma-informed model, so to speak, and I don't know that one has sort of emerged as a leader in this field yet.
All right, we've gotten a few questions about how do you engage your leadership, and if leadership is resistant, how do you work from the ground up?
That is a really, really good question. So, so we are fortunate to have an executive sponsor, well, 2 executive sponsors who really champion this from the very beginning. And I think part of it has to do with that not only did they know it's the right thing to do, but there has been so much buzz in different venues where they have been outside of our own organization that the writing was pretty much on the wall that we needed to be moving in this direction. So the visibility, I guess, if you can get your leaders to get more information in whatever areas that they respect outside of your organization, that's sort of one way to get that buy-in. The other, I think, is that, Children's Hospital of Wisconsin, we already do many, many, many things that are trauma-informed. And if you can do an internal assessment of, even if it's program-specific or department or unit-specific, what are those things that are already happening? Not only can it lay the groundwork for, look, we're already doing some of this, and here are the missing pieces. So where's the gap analysis, right? So where are the parts of this that are missing in our organization that we really need to be moving towards to create change from an organizational standpoint? I don't know what other organizations use in terms of forwarding ideas upward in your organization, but Children's uses something called an SBAR, and it's just really a brief synopsis describing the situation that you want to remedy, the background, really looking at, I forget what the whole acronym stands for, but really looking at sort of what your resources are and what are some of the risks involved if you don't do it, and what are some of the risks involved if you do. So, creating that SBAR, that summary, to be able to forward up to your leadership team through the channels that are already set up for decision making is an important one. And then what we did back last October was we have a consultancy relationship with the Andrews Institute and the Sanctuary Model, and we brought our consultant in for a half day. I don't want to call it a training, but it really was an opportunity for other executives and high-level leaders in the organization to learn more about what this sanctuary model is. And they saw a lot of alignment with our current culture shaping. And so it's very helpful to have the consultant come in, be Vetus, to work with us intentionally in setting up what that training or that half a day looked like, so that we were utilizing the terms that Children's already uses for our culture shaping and embedding sanctuary within that context. You want to add anything, Heather?
No, I would echo Jennifer's thoughts about the consultant, that having her here has really been wonderful and very useful in generating some of that desire to change.
I'm curious, since Jennifer, your position is to create this trauma-informed system. Do you think it's possible for a hospital to do that without staff completely dedicated to that kind of systems change? And also to piggyback on that, what kind of resources do hospitals need to really undertake such a large systems change movement?
Yeah, so there needs to be somebody who can lead the effort, because change management is not, any kind of change management project must have somebody to lead the work. And so it really is imperative that if your organization is going to embark on any kind of change project, that the executive leadership has bought into it, so that a portion of somebody's time is dedicated to managing the process. And so that needs to be very intentional. Does it need to be a brand new position? Maybe not, but it certainly needs to be called out in somebody's role. We were fortunate enough to be able to have received some private funds that enabled us to hire a project manager to really sort of focus on the implementation work of direct training and working with the direct individual departments and programs. I will say that it is, you can't just decide you're going to do the work. You really need to have those intentional conversations about what are the resources is it going to take for us to be able to do this. And we had some dialogue about if we are going to train every individual in the sanctuary model through what we're doing through phase 2, which is a 2-day training of all staff, what is that going to cost our organization in terms of people time? And that was an eye-opener for all of us to really have that dollar figure in front of us. It's going to cost us a couple of $1 million over the course of 1 year, 2 years, 3 years in order to be able to pull people away from their jobs to be trained for 2 full days. So it's really sort of pushing us to think about how do we do this, do it well, and do it in a way that is going to not impact the bottom line so significantly.
That's really helpful. I know we're just about out of time, but I wanted to take one last question, just to really expand how this is filtering out into the community. So you mentioned the importance of grounding the work internally before you take it external, but can you share how a patient or family member may receive different care or interact differently with staff, or have your patients noticed a difference? I know you're doing a formal evaluation, but I'm curious if you've heard anything informally.
Well, I certainly know from the Project Ujima has utilized actually 2 of the tools with their Project Ujima participants. This group, not only are they doing individual client-based services, but they run a summer camp for 6 weeks during the summer. And they utilize the community meeting with their clients, who absolutely love it. And it gives the staff a sense of where that kiddo is on the scale of on their mood elevator for the day. And so it allows a little bit of sort of intervention if necessary. And then they're also using what is called the safety plan in the sanctuary model. We call it the emotional management tool, but essentially it's at the beginning of camp, every camper has developed what are the things in their the things that they do that help to self-regulate their emotions when they feel their emotions are getting out of control. So if they're having a day or a morning that is filled with anxiety, what is it that kiddo can do to help bring his or her anxiety down? And it is about writing that down on a piece of paper and having it sort of available when that kiddo is unregulated. It also is a tool that the staff are using in that client's file to help the staff to help that kiddo get regulated again. And so those are the 2 sort of examples that we're using. In terms of have we had feedback from the patients and clients themselves, I don't know of any at this point. I don't know, Heather, if you've heard anything anecdotally.
Well, I think that this speaks to how many of these principles are interwoven with other initiatives that are going on. And I have heard of some conversation changers, I guess, and it's bringing awareness around that question of, not what's wrong with you, but really what happened to you and what has your experience been that has led you to this place or this point in time. And just taking a moment to reframe or reshape conversations or how people approach situations, I have heard that has already begun to happen.
That's great. Well, thank you very much to our presenters. This has been a very rich discussion, and we thank you for your leadership in the country to really provide an example for other hospitals to follow. So if you'd like more information about this or any other work done in adverse childhood experiences, you may contact me. This is Maggie Litkin at Health and Medicine Policy Research Group, or the Illinois ACEs Response Collaborative webpage. Like I said, we will be sending you this presentation in the next couple days with a survey and links to more resources. So thank you very much to our presenters and to our audience and to everyone who engaged with questions. Have a great day.